Good afternoon, I'm Dr. Lew from Department of Oral Pathology and Oral Medicine, Hospital Queen Elizabeth, Sabah. Today I'm going to share an interesting case with you, which is a swelling on the palate. Here we have a 36-year-old gentleman without underlying medical disease. He came to the clinic in December 2020 with a complaint of swelling on palate near the teeth in the past 3 years, suddenly enlarged in year 2020 with discomfort. He was having ongoing RCT of 2.5 and 2.6 following discovery of the swelling by restorative specialist. On examination, there is buccal expansion of the 2.5 and 2.6. Palatal swelling in relation with 2.5 to 2.7 is firm, and 2.5 and 2.6 teeth are having grade 1 mobility. The clinical photo shows a partially demarcated swelling at palatal of 2.4 to 2.7, having smooth surface. The site of first and second biopsy was at the pointed area. First biopsy was done in December 2020 and the result was radicular cyst. The OPG taken in December 2020 shows a well-defined regular radiolucency from 2.5 to 2.7. And the CBCT shows similar findings with slight palatal bone expansion and there is small buccal expansion. So what are your differential diagnoses? For me, my differential diagnoses include odontogenic cysts such as radicular cyst, OKC, or glandular odontogenic cyst based on the clinical and radiographic findings. And also the second differential will be the benign odontogenic tumor, which include amyloblastoma, adenomatoid odontogenic tumor, amyloblastic fibroma, and odontogenic fibroma. And thirdly, it will be a central giant cell granuloma. In March 2021, after 2.5 and 2.6 RCT was completed, cyst enucleation was done along with episectomy of 2.5 and 2.6. HPE shows a cystic lesion. The cystic lesion composed of fibrocollagenous cystic wall lined by the odontogenic epithelium of variable thickness, and in some areas luminal papillary projections are seen. Apart from that, the epithelium also exhibits multicystic compartments along with occasional presence of hobnail cells. The cuboidal to low columnar epithelium also contains abundance of mucous cells in the luminal layer. And in areas, we can see presence of basal and parabasal clear cells and also intraepithelial cyst. In the focal area of the cystic wall, glandular epithelium forming islands are also observed. Staining with PASTI shows positive findings in the mucous cells over the luminal layer. Both immunostaining with CK7 and CK19 shows positivity. Based on the histopathological findings, the diagnosis for this case is glandular odontogenic cyst. Glandular odontogenic cyst, or GOC, is a developmental cyst with epithelial features that simulate salivary gland or glandular differentiation. It is very rare among all odontogenic cysts and it favors the jaw with 75% in mandible, while lesions in maxilla tend to occur anteriorly. Clinically, it appears as a painless swelling along with root resorption, and the radiographic findings show well-defined multilocular radiolucency. In the latest WHO classification, there are 10 criteria listed and there must be 7 criteria out of 10 to make up a diagnosis of GOC. And it is a benign lesion, but recurrence rate is very high, so it has been suggested for surgical enucleation or resection to be followed by adjunctive procedures such as radiotherapy, and there should be follow-up for a minimum of 3 years. Differential diagnosis of GOC also includes lateral periodontal cyst, botryoid odontogenic cyst, low-grade central mucoep, as well as lentigerous cyst with mucous metaplasia. And this is not the end of the story yet. After 6 months, patient returned with persistent palatal swelling, and when we compare the OPG, the radiolucent lesion is still there, and the size remains almost the same. Hence, the surgeon decided to perform an incisional biopsy over the palate, And the HPE shows solid growth of tumor in the fibrocollagenous to hyalinized stroma. Papillary cystic structures are also seen apart from lobular growth pattern, and the tumor cells composed of squamoid, intermediate as well as mucous cells. Clear cell differentiation is prominent in this biopsy, and also in areas we can see cystic degeneration. At high power, we can see the tumor cells actually exhibit minimal cellular atypia. Staining with mucicarmine shows focal positivity, and similar findings for staining with PAS-D. So now what do you think? Based on the HPE findings, this is signed out as mucoepidermoid carcinoma. Mucoepidermoid carcinoma or mucoep is a distinctive salivary gland malignancy composed of mucinous, intermediate and squamous tumor cells forming cystic and solid patterns. This is the most common salivary gland malignancy in children and young adults, usually occur in parotid gland, palate, as well as submandibular gland. It could appear as a painless swelling, but in later stage, there will be pain, paresthesia, and tooth mobility. Radiograph shows unilocular or multilocular radiolucency with or without cortical plate disruption. The tumor can be graded based on proportions of tumor cells as well as with pattern of the tumor and presence of cellular atypia and so on. If there is necrosis or increased mitosis, this will be a high-grade tumor. And for low-grade tumor, it tends to show mammal 2 gene rearrangement, which is commonly seen in younger patients. And of course, if it is a low-grade tumor, the prognosis is better with 90% of 10-year survival. Patient was sent for CT scan and MRI after the incisional biopsy for surgical planning. There is a well-defined solid tumor in the left heart palate which erodes the bone and extends superolaterally through the floor of left maxillary sinus. It expands within the sinus and erodes through the anterior wall, but this could be possibly the window created for cyst enucleation earlier. And at the superior, it presses against the floor of the left orbit. Similar findings are seen in the MRI, and there is description of solid component within the maxillary sinus, which shares the same characteristic as its palatal counterpart. And in the sinus, it is mostly fluid component, and also the infraorbital format and groove appears unchanged. The circled area shows the perforation site by the tumor at the floor of the left maxillary sinus. This is the surgical specimen of left maxillectomy. We can see a slightly raised swelling over the palatal of 2.4 to 2.7. After the soft tissue is detached, a depression is seen over the palatal surface. After the soft tissue and tumor is completely detached, we can see the floor of the left maxillary sinus is still intact with one small perforation over the bariapical region of 2.4 and 2.5. It's just a small perforation. And the window on the anterior maxillary sinus wall was the one created earlier for cyst enucleation. So for the tumor in maxillary sinus, we can see cystic lesion lined by odontogenic epithelium, which is almost similar to what we saw earlier in GOC. Apart from this, we are also seeing hemorrhagic area with cholesterol cleft as well as hemosiderin deposits. And also there are focal areas of calcification in the cystic wall. At high power, we can see non-keratinized odontogenic epithelium with areas of thickening, and also there are a lot of mucous cells in the luminal layer and also intraepithelial cysts. For the tumor in the heart palate, it is totally different from what we saw just now. It is a solid tumor approaching the surface, and it composed of various types of tumor cells which are exhibiting a lobular growth pattern and intervened by fibrocollagenous stroma. And in this surgical specimen, there are more clear cells compared to the biopsy specimen. So the tumor cells are also composed of epidermoid cells, intermediate cells, and also mucous cells. And we don't see much cellular atypia here. Given the two different presentation of tumor at two different sites, so in this case, Is this the palatal mucoep that extends to the maxillary sinus, where initially it is a low-grade tumor, then transformed to an intermediate grade with solid area in the palatal counterpart? Is it a histological spectrum, because it has been speculated that GOC may represent the most benign end of spectrum of the central mucoep? And for invasion, mucoep often shows infiltrative growth by the non-cystic element, so the solid tumor will invade the bone and reach the sinus. Or could it be a central mucoep which arises from existing GOC? Over the years, there are reports on transformation of mucoep from GOC. However, central mucoep is very rare, with slight predilection for posterior mandible and females. It arises in tissue that does not normally contain salivary glands. There are two main hypotheses of possible pathogenesis for central mucoep. Firstly, the source of epithelium is from the ectopic salivary gland tissues, which could be due to entrapped minor salivary glands, embryonic inclusions, or displacement from the maxillary sinus. Secondly, it could be neoplastic transformation of odontogenic cyst epithelium. Odontogenic epithelial cells are pluripotent, means they are able to transform into other cell types. For example, mucous metaplasia in odontogenic cysts such as dentigerous cyst. And also, if there is neoplastic transformation, this could be attributed to factors occurring inside the cyst, including chronic and prolonged inflammation accompanying the cyst, various biochemical processes, and also the mechanical irritation of the cyst by the fluid, resulting in the remodeling and keratinization of the cystic epithelium. Thirdly, in this case, could it be a synchronous mucoep and GOC? Okay, what if we see areas that shows only GOC-like appearance without any solid counterpart? Okay, so there is a must for us to distinguish GOC from mucoep, because mucoep will show higher recurrence rate and there is high potential to metastasize, especially to the regional lymph nodes, and it can be lethal. There is some histological resemblance between low-grade mucoep and GOC, where it is difficult to be differentiated in a small incisional biopsy specimen. Waldron and Co. had mentioned that mucoep does not show swelling, spherical aggregates, or the epithelial plaque, but GOC shows typical thin epithelial lining without any solid epithelial proliferation as seen in mucoep. And mucoep also shows invasion on the cystic wall, but GOC does not. Remember this photomicrograph which I showed earlier? We can see there are a few epithelial islands within the cystic wall. So we were not sure whether this is just manifestation of GOC or it is something related to a low-grade mucoep. In addition, do GOC and central mucoep share a histopathological spectrum as in our case? And is there any mucoep-like changes in GOC that is associated with malignant behavior? These are the two questions that are still being validated by the researchers. Radiographically, Chan et al. Shows that central mucoep will often exhibit internal sclerotic bony masses as well as perforation of the external cortex with extension into surrounding tissue. What about IHC? Is there any specific thing that could differentiate GOC and central mucoep? In a study by Satoshi et al., CK13 is strongly positive in GOC, but is negative in central mucoep. This is in concordance with Zhou et al., where there are 85% of GOC cases positive for CK13, while it is only half of the cases of central mucoep positive for CK13. So CK13 could serve as a promising marker to differentiate GOC and central mucoep when other tests are not available. Mammal gene rearrangement has been proven to be related to mucoep, and a true GOC would not show this rearrangement. However, Some study shows mammal rearrangement was detected in one of the GOC cases, suggested that GOC to be a precursor of central mucoid. And there is one another study reported that mammal is not always reliable to differentiate central mucoid from GOC, as there is a lesion diagnosed as a cyst of unknown origin with features of slightly suggestive of GOC, was also positive for mammal rearrangement. In this case, we are not so sure of the origin of tumour, whether this is primarily from salivary gland tumour or it is arising from the existing GOC. However, due to appearance of the solid tumour, which is typical of mucoid, it helps us in our diagnosis. Whenever incisional biopsy for case like this received, interpretation must be careful, and definitive diagnosis will require clinical history, radiographic findings, and HB correlation. And not to forget the role of genetic profile. This will determine the definitive diagnosis as well as will help the surgeon in further treatment planning. Last but not least, if you have case like this where radiographic findings show a typical cystic lesion that leads to odontogenic cyst as the first differential diagnosis, a central mucoid can be included as one of the differential diagnoses as well to avoid misdiagnosis and delay management. These are the references that I used for this presentation. With that, I thank you for your kind attention.